Thank you. And hello, friends. My goodness, I am so thrilled to be with you all. It was an unexpected pleasure when Maureen and Nancy reached out and asked if I could step in and maybe I could talk a little bit about telehealth and ethics. And I wish I could be with you all to see you smiling because some of you may remember, well, this is where some of my work started. And it was a very big focus when technology first started to really become part of case management's world and our work and everything we're doing. Certainly, amid the pandemic, it's become, the latest, greatest thing since sliced bread. So, to that end, I prepared a little something for you. And as I often do with this chapter, well, here is the pilot offering of this session. Now, I many of you know I stop every morning, I take stock of what's going on in the industry, and it's so nice to see that nothing's changed, how stagnant it's all been. Yes, you know my sarcasm by now. I really do wish I could see all of your faces and the assorted grimaces because we all know stagnant is the last thing that these last 21 months have been. At the start of the pandemic, the Office of Civil Rights, aka the nice folks at the HIPAA oversight arm, they waived all potential penalties for HIPAA violations around healthcare providers that serve patients every day using technology. They felt we need to make sure folks are seen. They're scared to come into office spaces. In fact, offices, hospitals, healthcare organizations, they didn't want them. And as a result, technology, telehealth, telemedicine, bring it, the faster, the better. Now, this applied to all widely used communication apps, FaceTime, Skype, whether they were used in good faith for any telehealth treatment or simply a diagnostic purpose. It didn't matter whether telehealth was directly related to COVID treatment or some other care need, because as we know, surgeries, electives, office visits, everything virtually came to a standstill. There was expansion of business associate agreements to promote the ease of vendor alignment. I know a number of minds shifted. The bottom line is people had to be able to see their patients, but under the pandemic, there was a certain reality. The needle shifted, and this reality has become far more than the exception. And here we are now looking hopefully at post-pandemic, and the technology stakes and rules and regs keep on a-coming fast and furiously. Now, some of you might remember when the biggest issue was whether or not you worked for a covered entity or not. What was the electronic protected health information that was included? We all knew that. Well, what did I used to say? Best practice is good for, yeah, here I go again. Exactly right now. 11:55 a.m. Eastern Standard Time, because just wait for it, by 11:56 there will be another best practice coming down the pike, and that will make what you're doing obsolete. Right now, it is all about telehealth. I am 300% sure that everyone here has figured out that the regulations change by the second, the reimbursement changes by the minute, and the products and the best practices, those just keep rolling along. Now, the product has made our lives easier. However, remember, those best practices keep changing. Caution signs, caution cones, they are popping up in every element of our practice. And we've got to be mindful of every patient interaction and what access is like. I just saw a story this morning in one of the journals on telehealth, be careful, your telehealth provider may not be who they say they are. Can you really see them, or are they an emoji or an icon or a cartoon figure that is trying to replicate through artificial intelligence the human element? And is that actually treatment? Those sort of articles just really get me going. So today, what I want to do in our 75 minutes together or so is prioritize what you need to know to be effective with telehealth practice for right now. And that way, you got to win for at least, the next couple of months until things change again. All right. Here are our objectives. Barbara showed them on the slide as well, but really just to define telehealth and virtual practice. It's amazing. There remain a lot of misconceptions and confusion about things like telehealth, telemedicine, virtual health. Throw so many different terms out there, and talk a little bit about the pros and the cons to their practice. Dialogue a bit about what the evidence is telling us, that, like some of the regulation shifts, keeps changing and shifting each day across every population. And of course, depending on who's sponsoring the study, well, some of them are actually accurate. And yes, I did say that. Discuss what the regulations look like with respect to telehealth practices, and also what our established resources of guidance say. All of those regulations, as well as our standards of practice, our codes of ethics, and anything and everything in between that says, yeah, Barbara, you can see that patient virtually and in Massachusetts, but also Rhode Island and also New Hampshire. Yeah, not the same everywhere. And that's one of the things that keeps our heads spinning. And then I will wrap it up with a bow, and we'll talk about some of those ethical conflicts and how to mitigate them, as well as the effective do's and don'ts, if you will, for telehealth practice today. In my typical form, no conflicts of interest. You can read this. I'm not going to take the time to go over it, but any products discussed today really are just for the source of example and not to endorse the product. All right, so let's hit it. Telehealth. Telehealth 101. What are we talking about? Well, it is the delivery of medical practice, or telemedicine at least. Let me start there. Is the delivery of medical intervention, medical practice via some technology means. It could be digital transmission of medical imaging, rather. It could be assessment and remote medical diagnosis and evaluation by a specialty provider. It could be an actual video consultation with a provider or a specialist. It is the clinical, hands-on, if you will, relative hands-on medical practice that is engaged in at a distance. But then we have telehealth. Think of telehealth as an umbrella term. It is a broader terminology that goes for all sorts of interventions associated with health as well as behavioral health. Therapy and counseling, certainly, but also health education and coaching, nutrition, wound care evaluation is part of that, remote monitoring of vital signs, blood pressure or other vitals. Now, where it gets confusing is some people use them interchangeably. But telemedicine, know this, is always referring to that clinical, hands-on intervention that you would traditionally get from a medical provider. Now, telehealth has a couple of different elements to it. 3 in particular. You got real-time communication. That's when patients can connect with their provider via video conference. You need office visit for something. I had what I thought was a sinus infection last month. Boom, went to the app. Boom, requested the virtual appointment. Boom, got the confirmation in the email. Boom, clicked on the link. And voila, there was my provider interacting with me. Now, it may also happen via telephonic device. We'll talk about that a little after, but there are people that do not have access to or can't get access to a virtual visual platform. So as a result, they're connecting via telehealth. And my husband had trouble with the app for the virtual visit. So he had to go on and click on the number where it says, if you have trouble with the virtual visit, call here. Now, it was billed as a telehealth visit, but he was on his iPhone. Then you've got store and forward. Store and forward is a little different. That's the transmission of data, the images, the CAT scan results, the MRI, sound or video from one care site to another for the purposes of evaluation. My neurosurgeon wanted to see the x-rays that they had done and a CAT scan they had done of my back. Boom. Radiology sent it over. Boom. That's store and forward. Then you have remote patient monitoring. That's where, we're looking at vital signs, we're evaluating them. I think a lot of people almost know remote patient monitoring in our world before real-time communication and store and forward because of all those remote devices I used to talk about and concerns about hacking into diabetic monitors and blood pressure cuffs and all that went on with the earlier generations of technology and healthcare provision. Now, some of you are probably sitting there going, but Ellen, what happened to mHealth? Why isn't that included here? Well, it is included. And, we're talking about things like health education, information that comes across apps or a mobile device. But the mHealth applications are less commonly referenced in state policy, which was something I didn't know. I found interesting, and it seems like it's a lost opportunity, especially with the way they're being utilized. Certainly for mental health right now, they are the big go-to. And I don't want to go down a rabbit hole with it, but the question is how mHealth should be incorporated within the regulations. Now, we've got a lot of folks in this space, and I'm so thrilled to see so many of you. I love seeing participants, and I just wish I could be there to give you all a big hug, but all right, I digress. But I got a question for you, and if you want, whether your Zoom app has your emojis at the top, at the bottom, I wonder how many of you used a mobile app to connect with your provider or about your practice, or better yet, for a virtual visit. My guess is the majority of you in this room over the last 6 months to a year have engaged with mHealth for a virtual interaction, if not telehealth all overall. Now, let's talk a little bit about the regulations and the coverage. So, whoops, there we go. I thought I missed a slide. I apologize. Now, there used to be a time when we could provide very clear benefits and reimbursement for telehealth. Not so much. They have become the biggest target across every state and across every jurisdiction, and that includes across the globe. Now, pre-pandemic, and by far my favorite site still remains for regulation, the National Conference of State Legislatures. That's www.ncl, ncsl.org. And all is typical, all of the citations on the slides, the references for them appear at the end of the presentation. You'll have access to them. And I finished these slides, Maureen knows, last week. So this information is hot off the press. Those links should all be good. I have resource links as well. But if for some reason there's an issue, please let me know, because the URLs change very rapidly. So 35 states required state-regulated individual and group health insurance to cover telemedicine. Now, that grid of each of those states actually is the Volk citation, which is a report that was done on the Commonwealth Fund site. 25 states required insurers to limit cost sharing, while 15 states required insurers to reimburse providers for a telemedicine visit that would be on par with the reimbursement they provided for an in-person visit. Now, a lot of states pre-pandemic, one of the big challenges were that to engage in a telemedicine visit, there had to be a prior in-person visit with a patient. Much of that pre-pandemic, or amid the pandemic rather, was waived because they didn't want the pandemic to be an obstacle to accessing health care. Now, only 3 states, Connecticut, Colorado, and Delaware, required coverage of audio-only telemedicine visits. And it gets confusing. The states continue to shift and pivot, everybody's favorite or maybe slightly overused mantra of the last couple of months. But you see, Medicaid and private payer, all the lovely blue states, Medicaid only, the orange states, the gray ones, it was limited information or they don't have and they're listed. But the states have continued with Medicaid policies to adjust them. They've also continued with Medicare Advantage plans to adjust those as well. Information coming out, because we're right now starting open enrollment, is all the new toys that are going to be covered with Medicare Advantage plans moving forward, and all of the extensions to telehealth way beyond the end of the year and into 22 as a permanent benefit. Now, moving forward with respect to Medicaid, the state policies include some type of reimbursement, but the scope of those, all different. All the states and the District of Columbia, as you know, I often say, strives to be a state, reimburse for live, in the moment, in sync video services through their Medicaid programs. At least 10 of the states stipulate Medicaid coverage and reimbursement for telehealth, telemedicine, virtual and telephonic interaction. And those keep varying. And the map, they update it regularly. It may look different today on the NSL site. I actually looked at it last night and it still looked the same. Now, the private payer policies, those have really stepped up and tried to continue to be on par and ensure that their customers, patients, members, consumers have access to telehealth, because they know that a lot of people delayed access to a provider, delayed care, particularly older adults during the population that may not be as savvy, or patients at risk of social determinants of health and mental health. I can't get through a presentation these days without mentioning those, but lots of literature about challenges with their access, consistent access to Wi-Fi and broadband, to the point that either it was insufficient a signal to allow them to use virtual interactions or telehealth interactions, or their device actually didn't allow them the ability to access those platforms. Now, at least 43 states and DC have some sort of private payer policy for telehealth. The state laws governing these will vary as to whether they require coverage or reimbursement, include all services, or set the same rates. So again, it continues to be a moving target from state to state. I know that your brains are probably buzzing with questions. I'm going to try to move through this. We'll see, Barbara, if you see something that is a must in the moment question, I'm happy to answer it, because you know I like to minimize any confusion about anything I'm saying. So then just feel free to pop on and go, Ellen, there's a question that must be answered. There we go. All right. Now, it has been a coverage extravaganza, and that's the best way I can think of to describe it. Now, the Cures Act kind of got the party started. Increased funding for telehealth. CMS expanded coverage for all telehealth providers. 19 through all of the public emergencies that were going on, there were considerable enhancements to coverage. The CPT codes have now been permanently added to the physician fee schedule for 2022. All right? Managed Medicare, Medicaid plans, Medicare increased payments across evaluations, and they also temporarily waived that audio video requirement for telehealth services, again, as a way for those without access to those platforms to be able to access a virtual visit so that they can call their provider and still, or call their practitioner and still have the benefit of consultation, a behavioral health or counseling session, a coaching session, and have it be reimbursed. Now, the Medicare and Medicaid point of service modifier was also adjusted. This allowed for reimbursement equal to what it would have been if the service had been filled in person, which was a big issue to really frustrate coders, practitioners, and revenue cycle specialists. So that when billing telehealth services, healthcare providers, well, you gotta bill your evaluation and management codes with a place of service code, which is O2, along with a GT modifier of 95. Those without the modifier will not be reimbursed. It is that simple. It is amazing how reliant we become on these codes to guide the revenue management cycle in our organizations, but that is their role. The GT modifier of 95 basically says to the Medicare payer folks, guess what? Services were delivered via telemedicine. And then there were additional codes. So, we had the HCPCS codes, Q30104. That is in response to hospitals and facilities to be able to bill for telehealth. The originating site facility fee when a hospital provides services via telehealth to a registered outpatient of the hospital. Yeah, that's the key. They must be a registered outpatient. And then under the Emergency Waiver Act, the patient can be located anywhere, any provider-based department, including the hospital or the patient's home. Now, the Cures Act is going to keep expanding. We know that, and all the literature says so. And yeah, if I'm looking at my notes a little bit more for this slide than other ones, is because I just wanted to get it right. You got to keep checking the CMS site, because you know the mantra. This is good for 12/15 today. Hopefully it's good for a little bit more than that. at least a good few months, but know that there will be further expansions coming down the pike, Medicaid and CHIPS integration for the Children's Health Insurance Program, lifting of some of those service and site restrictions, and then adding to the Medicare roster. Clearly, the sky is the limit, and we're going to keep on moving this train forward. So let's look a little bit at some of the evidence. Yeah, that doctoral program still messing with me. One more year, but me and my data. And we love our data because it tells us a lot. Now, I could have gone into a really deep dive. I didn't want anybody throwing anything at me, but clearly here is a smattering of some of the data. Utilization is up for telehealth across every population. And when I saw this number, 30 times higher than it was pre-pandemic, but it continues to rise. Certain specialists are accessing it, obviously in the mental health arena. It's up considerably. For psychiatry access, if you can find a psychiatrist, which continues to still be an issue. Now we're unfortunately seeing a ripple effect in mental health in terms of accessing mental health providers because of a workforce crisis. I had a dialogue last week with an executive director from the National Association of Social Workers who was sharing with me, again, a lot's been written about by me and others on collective occupational trauma, workforce stress, burnout, and retention. But there is a workforce crisis for just about every discipline that's been on the front lines, but especially for psychiatrists, for those seeking substance use treatment. Well, telehealth claims are up considerably. Now, Medicare beneficiaries are up. Providers, well, yeah, everybody's doing it, so it must be popular. And for rural communities, it is become a very big fix to address the provider shortages that exist in health practitioner shortage areas, as well as medically underserved areas and populations. Now, the states that have those biggest areas, California and Texas, continue to be challenged by those. The states with a lot of rural regions, my adopted home state of Virginia is really struggling at this point. A lot of states within the rural region belt, Arkansas, Oklahoma, and up in New England where you folks are, while you have lots of providers, the Wi-Fi and broadband access is a challenge to access them clearly, sufficiently, and of a quality nature that we as case managers expect without an interference of signal during the treatment time. So those are some of the hiccups we're seeing. We got promises, but we also got some pitfalls. Now, what would a presentation be on any topic without some slide to address costs? Well, in this arena, we know that there are a lot of wins. And so it usually costs facilities about anywhere from $15,000 to, add another zero, $150,000 to add some sort of telehealth system. And I'm talking about a system rather than a business license for a HIPAA compliant platform. And I'm just going to throw some out there again, just being given for example, whether they are Skype for Business, which is HIPAA compliant, whether they are DBH-C, whether they are Zoom Health, some of the larger and on with a list of products, but lots of data to support that. For that implementation cost, the return on investment, well, it's pretty massive. So this was one. There have been a whole slew of studies lately. This was one that just was released in 2020. Nice chunk of change per patient, about $8,566 total service cost savings rather, versus what a traditional in-home home care program provided. 6 months, about 13,000 per person. I mean, we start to add up there. It's far less expensive to render. There's a lot been written how amid the pandemic, the office footprint of organizations is changing. How many of you have not been in an office space and now work remotely from home, whether every day or several days a week? My husband has been in his office, I think he goes 2 times a week, and sometimes his boss says, come in once a week. And offices are getting smaller. The footprint of large healthcare organizations within big office buildings is getting smaller. And so then you take something like telehealth, saving over almost $11,000 over 8 months. That's pretty impressive. And I don't think it's slowing down anytime soon. But here's the kicker. Here's where we start to look at, well, it's the greatest thing since sliced bread, or certainly the internet, but is it good for everybody? Well, so this was a study. You gotta love the research and how fast and furiously it's coming out, and whether it's through the Journal of American Medicine or Lancet, lots of studies focused on telehealth across populations. Now, this one in particular stemmed from Chicago, so sorry, not New England, but it looked at 700 patients who were enrolled at an academic medical center or a federally qualified health center outside of Chicago. Right? So we know those FQHCs, they are taking care of the patients closer to the poverty level, lower socioeconomic status, lots of chronic health, comorbid health and mental health issues, and a high incidence of health literacy challenges and language proficiency challenges. So what this study looked at and showed us was that those with limited English proficiency, half as likely to have a video visit, half as likely to think a telehealth appointment was just as good as an in-person appointment, and were less likely to find telehealth useful. At case managers, you know the value of outcomes. And these outcomes tell us a lot. Think of your own populations. You don't understand what was discussed, you're not going to know what to do, and you're not going to have successful outcomes, or it's certainly going to be a lot tougher to manage those at-risk health behaviors that you're trying so desperately to shift. This next study looked at accessibility, and it was very clear. It was out of Penn Medicine, surveyed providers. Now, Penn Medicine is part of a region that is fraught with social determinants, rural health challenges, patients that live at the highest of socioeconomic status and the lowest, and many really struggling. And among the principles that they endorsed, this was their list of what telehealth products really need to include to have successful telehealth visits. Here were a few. If I were with you in person, I'd be saying, all right, shout them out to me. But I'll make it easy, and I know, time is of the essence, so I know, Ellen, just get to it. Nothing that requires a patient to download an app. Patients are often worried about the costs of that. Will it be free? A lot of apps are not. They take up space on the phone. And while a lot of products now, and a lot of providers and a lot of state Medicaid plans offer patients a free device, especially if there is someone in the house that's in that residence that is over 18, that doesn't mean that the broadband allows for a solid download or an appropriate high quality connection. The provider There must be integrated, the ability for multiple providers to sign on, but the patient only has to sign on to one site. So that less is more, they don't have to do a lot, and that telehealth use isn't necessarily connected to the patient portal. One of the things they found in the study is that patients could access the portal, but they were not able to either access, use, know how to use, or feel comfortable on a virtual platform. And I ask you all, think, for some of you, how comfortable was it to get used to looking at your provider? What happens if you just want to email your provider? Can you call them up and talk to them on the phone? Not everybody has access to the internet, and there need to be allowances for different types of internet usage and device usage. This was a biggie. Virtual patient waiting rooms, knowing that there was a time frame as well where providers could send messages in there, chill, I'm running late. That visit I had with my provider that I talked about on the front end, well, I was on at 10:30. Where were they? They're supposed to be on at 10:30, 10:35, 10:45. Did you see them? I didn't. Now, I'm savvy enough and comfortable enough, and usually on most days, have no language proficiency or health literacy challenges, that I knew. Call the doctor's office, see if there is a problem. Sure enough, there was. They were able to find out there had been a patient emergency and it needed multiple providers, and it was obviously creating a hiccup in their scheduling, just like happens in a regular office, in-person office. But how great to be able to see, for the patient to see what the status is, and for the provider to be able to communicate directly with them. The capability to pull on multiple providers, the nurse practitioner, a different specialist who the patient might be seeing, or to share the screen so that the providers could all see each other. You could do like a Brady Bunch picture and have it be a group meeting. At the end of the day, these all promote greater accessibility and comfort for patients. And in the long run, more use means greater patient satisfaction, something that organizations are still measuring. Oh yeah, those quality metrics. I had to throw that in. All right, let's talk about ethics. And obviously, I could stay here a really long time, but let me make it easy. We're going to hit a lot on this one slide. Telehealth has done a lot. Telehealth has promoted access. It's removed a lot of, not all, but a lot of the geographic constraints. It does allow for service delivery across state lines, but we got that little compliance factor. We got the scope of practice factor, and we got the eligibility to practice in that state. It varies for every professional discipline because interstate practice acts can still limit who and how telehealth can be used, who can be reimbursed by them, professional licensure for each discipline. It may be based on the language in the primary state licensure, especially for disciplines with compacts. It may say that the person needs to see patients who have a driver's license in that state. So it may be you can only see patients where the patient physically resides. So for me, in Virginia, the language is very clear. I can only see patients whose driver's license and residence state, they live in Virginia. In some cases, it's dictated by where the patient's being treated, as in medicine, sometimes nursing, physical, occupational, and speech therapy. Now, states also have something called guidance documents. These are documents that will further detail practice but they're not part of regulation, formal regulation. They are part of the state mandate for how to practice. I know. I need one of my legal buddies. Well, we'll see Lynn Muller later, to talk a little bit about this very topic. But here's where the rubber hits the road, because these start to get in the weeds of regulations. And there's specific language that can reinforce a practice concept, like, I'll quote my own state: telehealth must be practiced with patients who reside within the state the professional is licensed in. Now, it's really an extension of what is talked about in the licensure scope of practice. But some people like the guidance documents. They're sometimes easier to read, easier to find, print out. They're usually by number on the licensure site. Now, we've also got all these temporary and emergency declarations. If I hear Executive Order 47 one more time, which is what it is in Virginia. But for example, the Federation of State Medical Boards, the physician equivalent to the National Council of State Boards of Nursing, they list 18 states plus the District of Columbia that have telehealth waivers that allow practice by out-of-state physicians, or don't limit if there was a pre-existing relationship, or the access to the person in person, or audio requirements. Now, the National Conference of State Boards of Nursing, I was on their website. They've got a beautiful document. You got the URL for it in the resources, don't worry. But it lists every state, and whether there's a licensing waiver that allows you to practice, and how the compact factors in. I thought that was really cool. Now, prior to COVID, you would see, I don't want to confuse you. Prior to COVID, you would see a lot of these declarations traditionally after a national disaster or a local disaster, maybe a mass violent event. They are now the norm after COVID, and they are ever changing and evolving, because in one breath, it might state that the temporary waiver or emergency declaration will expire. Well, they did just expire on September 30th. Now they're December 30th. They could speak to the language, the time frames for the declaration. Many of those in fact, the majority of those put in place at the start of the pandemic are still ongoing. They will traditionally also allow for someone of a particular license or discipline to apply for licensure in a state. So, and I keep citing Virginia, but I could equally cite Massachusetts, Rhode Island, New Hampshire on your board of practice websites, whether nurse, social work, occupational therapy. During the height of COVID, and even perhaps at this point, there's usually language about temporary licensure. And if you want a temporary license to practice, like for telehealth, click here. It's a usually pretty simple process. And obviously this is for disciplines or states that don't have compacts. Many of them also use the language that if you want to practice in this state or with this population for more than 6 months, you got to go through the regular hoops and hiccups and obstacles and all those moving parts to be able to apply for full licensure in the state. Now, proficiency of telehealth is a really interesting topic. Our workforce and just about every stakeholder and consumer, we were tossed into the deep end of the pool without a life preserver or a boat of any type. Most disciplines include some language in their licensure scope of practice, in their code of ethics, in their standards of practice, that you don't practice outside of the lane. You don't practice outside of the scope of your expertise. Well, that leads to making sure that the language in your malpractice is clear. I had to dialogue with my malpractice provider to make sure that I could interact in the Commonwealth under their policy with the same protections and precautions as I would in person. You need to check. You can't just make the assumption, especially if you're going to practice across state lines. You need to make sure that your malpractice covers the provision of telehealth or telemental health services and will allow you to do so across state lines. Now, often they will say, well, it will be based on your scope of practice. Nancy, check with practice in California. Barbara, check with practice in Texas. Dolores, check with practice in Maine. You've got to make sure that you're looking at all these things in the consideration of your practice and that you have appropriate liability, because otherwise it's a problem. And you guys know, even a short presentation, I'm going to throw in a little case scenario for you. So, case manager named Leah, she attended a training on telehealth. She feels totally ready to do a virtual session with patients. So she meets with each patient to let them know this new treatment is coming. How exciting, she says. I've done plenty of FaceTime calls with friends and family. I got this covered. Several of her clients, well, they're not interested. They tell Leah they're much more comfortable meeting her in person and talking on the phone. But Leah insists, and virtual sessions initiate. The case manager should. Well, here's the thing. I know. Here's where, if you want to put it in the chat, you can certainly feel free to put it in the chat. Here's where lots of things may have to happen. Now, so I'm going to start with the newest code. And yes, I have those social work letters after my name. But NASW just, in fact, hot off the press in the last 2 months, they updated their code of ethics. They talk a lot now, and they change the language about informed consent. And a lot of the language in many of the codes and standards of practice is shifting because of the lessons learned. It had changed enough in the scope of technology. So here is what the language is, that social workers are beholden to assess client capacity and provide informed consent. And when using technology to communicate, verify the identity and location of clients. Why? Because it's what the regulations state. It's what codes state. It's what all the established resources state. And it becomes critical to your practice and your liability. In 2019, when the American Nurses Association published their core principles on connected health, which is a great document on their website, here's all the cool stuff they talked about. Right? They wanted to make sure that nurses had a working knowledge of these issues. No, you can't just be tossed into the deep end of the pool. I know that that's what everybody's had to deal with. But you still have to be mindful of the laws. You still have to be able to meet, I love that second one, meet the state-specific regulatory institutional requirements aligned with the scope. I can hear Lynn Muller smiling. I can see it. I can close my eyes and see it. Safeguards when transmitting electronic information and communication using technology, and just continue to update your practices. Be mindful, keeping your eye on the ever-changing connected health climate. NASW also added language about, hey, what happens if, Wi-Fi goes out, broadband goes out? Think of sometimes what we are tasked to assess in the moment. And that we have to, as professionals, make reasonable efforts to keep the patient safe always. And that means ensuring that somehow we can get back in the phone. A lot of people have said, okay, we're going to do a virtual visit, but here is my phone number. in the event that we get disrupted. I do that as a routine standard of practice. Here's a number that you can text me in the event that something happens. But it also covers relocation, illness, mental or physical ability, as well as, unfortunately, death and demise. CCMC has principles 5 and 7 about obeying laws and regulations. And again, keeping that competency at a level that your clients get the best of the services that they are supposed to get, and relative to the needs and circumstances that they have. Sorry, I got an itch. All right, consider this one. Dante, he's got a dedicated Zoom URL for his room. All of his virtual meetings are here, whether with colleagues, and all of his case management patients, their families, providers, everybody comes into the room. He's got over 75 patients, so he doesn't leave a lot of time between patient meetings. I got a really good sense of time. He always says that to colleagues. I got this. Well, one day he had a patient emergency and he ran over for a visit. The patient was expressing suicidal ideation, so he had to take his time. He had to engage the patient. He's working through a safety contract with the patient, and poof, another patient appears in the Zoom room. You can't make this stuff up. This actually happens very often. Dante should have done a lot of things. First of all, Dante should have had it set so that he has to let people into the room. That's a really easy thing to do. He can also set a code so only people with the code can access. He can set the timing a little further apart, maybe at least 15 minutes. He can keep a clock or timer in front of him. Not so competent because our practice easily gets interrupted. I mean, what case manager doesn't know that? I got one more for you. One more because I just couldn't help myself, because this happens. Your manager at Ipswich Managed Care Organization called a meeting announcing a brand new practice. Since Wi-Fi and broadband are spotty, patient interactions will remain telephonic, with all of them recorded. When you ask about patient consent, you're told, we need to implement this policy ASAP. Patient consent is not required. Yes, you might be looking for a new job. You might be reaching out to CCMC for an advisory opinion. You might be reaching out to your malpractice, your legal provider, calling a meeting, causing a riot, advocating. Every standard, every code, every regulation says, no, not cool, not cool. And of course, the legal standard for CMSA, documented informed consent, where client consent is a prerequisite to the provision of services. So what do you need to do? Well, got about 16 minutes to finish up. So what do you need to do to get ready for this practice shift? All right, here are a couple of things. First of all, and some of this to you may be intuitive, but I wanted to provide you a list of kind of those best practices so that you can refer to it, because sometimes, boy, I don't know about you guys, but these days my brain is leaking out my ears at a regular pace. And that's because of all we're dealing with. So the first thing is try to use a quality webcam and telehealth platform, but make sure you know how to use it. I know that sometimes you don't get the say in what your organizations use, but you can make sure that you're proficient in how to maneuver it and how to engage with it in a way that's appropriate. Set that webcam at eye level, maybe even practice before. I actually do that every time I give a presentation. Now I'm hoping, because I moved the screen over, that my head's not cut off, because I decided to wear higher shoes for you all. And I suddenly got down here and went, oh, wait a second. My head's here. Now imagine if I came all the way here, or I suddenly got so excited I was over here and I've disappeared. But you want to be talking to the person. You don't want to be just a talking head either. Ideally, it would be nice to be able to see you from the waist up. Now, you want to use a professional backdrop for all your virtual interactions, your sessions, whether it is a muted backdrop. You know, we've gone from all of those cool backdrop screens that were coming up. But guess what was happening? Some of you may have known that dependent on the Wi-Fi signal and the backdrop, you might have ended up, or the patient might have ended up, but more importantly, you disappearing in the backdrop. You may have become, you know, like some alien being because you would dissolve into the screen, which could be very disruptive for patients and families as well. Now Zoom's gone to this muted backdrop, which a lot of people like. I have the screen. Sometimes I'll be in front of a picture, but you want to make sure that it is appropriate to the setting. You also want to be mindful of the lighting, whether you use a product like a ring or one of the lights that you can put on your device. And I don't mean the outdoor ring for doorbells and to be able to see packages. There actually, some of you may know, there's a product that's called a ring, and there are other products like it. They sit on top of the monitor or screen and provide some background lighting. I would also encourage you, when you do use it, make sure to try it before each day. It can be altered just simply based on your broadband signal. So you can suddenly appear lighter or darker. Make sure you check your privacy settings on the device that you are using so that you don't have a moment like Dante did, where people are just popping in when it is not appropriate for them to do so. Try to be on time as you can. Nobody likes to be left waiting. You certainly don't like to be, and you want to make sure that you keep on a good flow with that schedule. Now, one of the things that has been a big deal over these last couple of years is with the increased use of technology and telehealth and virtual meetings and interactions and people working remotely from home. From here up, they're dressing the part. Unfortunately, then they have a situation where they need to get up. And yes, we've all seen the YouTube videos where people get up, but they don't have necessarily clothes on from the waist down, or they have pajamas on, but try to dress the professional part. It makes me feel better. It makes me feel like the professional I know I am. If I spend too many days wearing, even if it's a cool modern sweatshirt that says something inspiring, no. There are days, and some days I'll just get dressed up like this, and my husband will go, "Are you giving a presentation today?" I'll go, "No, I have client meetings. I have a couple of other meetings that I need to do, but I'm going to be writing today." Because you're writing like that? I go, "Yeah, because I wanted to." It helps to keep us in that professional space, which is so important to that identity we retain. You want to make sure to have the patient's information available so you're not juggling with other screens. And that leads to the next one of engage with the patient. Now, I know a lot of people, and I do as well, you might have multiple monitors that you work from. But what can happen is you're engaging the patient, but suddenly you're looking at another monitor for patient information, another monitor, things are alerting you that there's an office visit or a staff meeting. You might have notifications popping in. If you need to look away from the client, let the client know, because everybody likes when people talk to them, not at them or at some space. Telehealth can be tough enough for some people and populations. You want to stay in mind of Wi-Fi challenges. The other night, I was in a meeting, and all of a sudden, something popped up and it said, "I've been made host." And the next thing I know, there was a message in the chat from the person running the meeting. "We have terrible storms happening here. I wanted to make sure there was an alternate host and I knew I could trust you, right? If there are Wi-Fi challenges, if there's bad weather happening in your region or the region where the client may be, stay aware, make sure they have a phone number. As you're interacting on telehealth, we can very easily just end the session in a very different way than I think we do with other interactions. I was on a call this morning and I was muted, and I meant to end my mute, and instead I accidentally hung up. That was a little embarrassing. It was fine. I was done with what I was saying. I was able to call back in. But you want to make sure, even leave yourself a note that before you finish that telehealth interaction, just like you would in person, be clear with your treatment actions, be clear with any recommendations or any follow-up that needs to happen, maybe even the next meeting. And be mindful when there are updates. We've had a couple of updates since the latest Apple update last week, and it's still going on. Some people may have had an issue getting on with Zoom. I know when I first got on today, part of the reason I got on was because there had been a series of updates and there had been some challenges, and I wanted to make sure I got on. So if I popped in the middle of Nancy, I'm so sorry. But you want to make sure when updates happen, sometimes even though your machine is or your device is set to update, you need to go back in and set it to update, do the update. My stuff is all set, but sometimes it still needs my permission. Communicating, being empathic, and expressing that kind of meaningful human interaction that is so much a part of who we are as case managers and health and behavioral health professionals has been a little challenging for many folks. And so, here's just a little list. You want to be effective with communication. You want to talk to the person, not down to them, and use empathic listening. And what do I mean by that? Well, a couple of things. Stay aware of your verbal, nonverbal communication as well as your own. You can still shake your head. You could still smile. You could still be mindful of what they're saying. If you're not sure what they're saying to you, say, gee, I want to make sure I heard you correctly. Some of the same mantras still apply with empathic listening and reflective and active listening that we would normally use. Don't just say, oh, I get it, as a way to get them off the phone. We all know that. But, we can be rushed and get distracted, especially with the various notifications that come popping in on our screen. We want to be mindful of saying, gee, I want to make sure I understood you correctly. If we were in person, I know it can feel easier. So just, this is what I understood. Was that correct? Make sure not to use a lot of jargon. Again, that less is more mindset. Speak to the person, use that, we used to say a 12th grade reading level. Well, now it really is more like a 7th or an 8th grade reading level. You want to be able to speak to where the person is at. And that may mean they are very, very uncomfortable with a virtual platform. They may be very uncomfortable with a telephonic platform. Be mindful of how quickly or how slowly you speak. Give them the time and space to speak. If there's silence, leave it for a bit, but check back in with them. Ask them how they're doing. Be mindful of your body posture. You don't want to shrink. You don't want to be sitting up so high that it's like you're looking like you're above them, like it's a control issue. Be mindful of facial expressions. Also, it can be very critical to, if you were to close your eyes, how differently would you be acting with the person if they were right in front of you? I'd like to think that at this point in time, a lot of people, and this is what I'm hearing from colleagues, are saying, it's as if we've always been interacting this way. It's not as big a deal, but we can't make that assumption with everyone. We still have to make sure to be respectful of who the person is, reflect that empathy, that warmth, that caring, the concern, and always, always, always don't just say, yes, I totally understand. I know exactly what you're saying. No, you still don't. You don't understand exactly what they're saying or who they are because you're not them. People still need that time, that patience, that that opportunity to feel comfortable in what can be still a very uncomfortable situation. I felt like I needed to add something about Zoom fatigue because people are still dealing with it. Whether you use Zoom or any other virtual platform, I mean, I gotta wonder how many of you have gotten texts from colleagues or texted colleagues saying, please, not one more Zoom meeting. Please, can we just talk on the phone? I love seeing you, but I've done 7 of them today and I am bleary-eyed and I'm out of eye drops. I need the Amazon drone to deliver them. Right? Couple of things that you could do to still be mindful, because guess what? None of this technology is going anywhere. It's not. Make sure to keep those breaks going through the day, especially if you have back-to-back virtual interactions. Get up, walk away from the screen. Sometimes you can keep the meeting very brief. Sometimes you can't. But be mindful of when you got a lot going on the screen, the brightness of the screen. You could always tone it down. I had a friend reach out to me. I didn't know what that button on my computer did, and accidentally my cat walked over it. Well, what they were talking about was their cat walked on their laptop, and at least I'm looking at the top of my MacBook Air. There's a little brightness screen that's above the numbers. Well, they didn't even know that that was there, and they couldn't imagine why suddenly it got really, really dark on the screen. But there are lots of things that you can do to reduce the impact of that screen on your eyes, and eye tearing and things like that. One of the things I do, and I've just done it now, and actually I've done it for the majority of the presentation, I've hidden my self view. I can't see me. I can see Barbara, or her space. I can see the CMSNE panel, but I can't see me, because it becomes distracting. And then the focus, if this were a meeting where I were looking directly at all of you, well, imagine what happens. I start looking over to the right at me and anybody I can see instead of the little green light. If you're meeting with a patient or family, you end up looking at you instead of them. And you get distracted by that because we pay a lot more attention to ourselves. And that's one of the things, that extra energy also contributes to Zoom fatigue. We want to be mindful of all the multitasking we do. How many things can we juggle when we're on a virtual call? No one will see, well, if I have my phone in my lap, or if I'm petting my cat, or if I'm checking my calendar. You know what, the more you do, the more distracted you can get, the more you won't hear something that a client or a provider or whoever you're meeting with is saying, and it drains you incredibly. The more ways your brain is pulled, the tougher it gets. And just like we have remote days, schedule a day where you don't look at the screen, or you look at it as little as possible. Everyone thought, okay, we're going to look at big screens, and everybody got monitors because it's better than looking, at your mobile phone. Well, that's not necessarily the case. Sometimes the bigger the screen, the tougher it is on your eyes. And, taking that screen-free day may be just what you need. And, of course, switching to those phone calls. Lots and lots of resources for you now. These resources on this page all have embedded links in them. So the American Nurses Association document, the Center for Connected Health Policy, has fantastic information on what is happening from an advocacy standpoint and regulatory standpoint across the states. CMS, that's the direct list to all of the telehealth services. And then you have the professional association and entities, as well as the National Conference of State Legislatures. telehealth.org is probably one of the longest standing organizations and educators of telehealth licensure certification and information. And so I provide their website as well for your interest. Got to remember, in the context of telehealth, there's a really big ethical and legal component. But I want you to remember that the one ethical constant you can always do amid all the swirling regulations and orange cones and caution signs is to do the right thing. The right thing is to follow the regs, to follow the best practices, check those best practices, and keep on doing the right thing. I want to thank you all for inviting me to be with you today. I hope this has provided you what you needed. And of course, happy early case management week. Yay. Please enjoy, please celebrate. And I think that I have even stopped in time for a couple of questions, Barbara. I don't know, you tell me.
No, I think you have. Thanks, Ellen. This was very timely and information-packed session. Couldn't be more timely for sure. We do have 2 questions in the Q&A, but I encourage anyone else who has any to write them in while I read these 2 to Ellen right now. One is more, this is from Lee. It's almost a comment, but might actually have an answer from you. It says, thoughts on a provider doing a brand new patient appointment on a telephone only. The patient is not mobile. The practice does have a video app, but was not offered to the patient. Seems like a lost opportunity. So it sounds like an access issue on the patient side. So.
Well, and yes. And I guess one thing I would want to know is the population seen by the practice ones that it could be at risk for them, right? So that potentially they may know that this patient population, 75% of them never like to use the virtual platform. So that this provider has been told, you know what, for the first time, you can schedule it by telephone, but I would wonder if it was something on the provider's end. I would say that if the practice has virtual health options or telehealth options, it should always be offered, but perhaps say it in a way to the patient, maybe, if you're not comfortable or you've never done it, we can instruct you on how to use it. We can do a first-time telephone call. I mean, there are lots of ways to have that chat and ease someone into it, because it can be very daunting. But I would wonder here if it was more daunting for the provider than the patient. But you
know. So Lee, she followed up with exactly, it was asked.
Okay. So it was asked and the patient denied it. Of that, and the practice has to also know their patient population. You know, is there a literacy issue? Is the patient, is it a person with disabilities that feels uncomfortable being on the screen? You know, a little deeper digging about how they can best support the person's health. Telephonic may be easier, but it may not be better. And let's give it a try. Maybe a practice, which I know is time consuming and not always reimbursable, but you know, sometimes being proactive gets you a lot more than being reactive. So.
Okay, and we actually have another anonymous attendee who posted a question. Since the pandemic and the increased ability to work from anywhere, would a remote or telephonic case manager need to be licensed in the state they are working from, as well as the state the patients that they are following?
So as I mentioned, and on slide, well, on my page 16, but it's not. I know it's further on. You really need to check your regulations for your discipline because they're going to vary. Now, for my social work license, I can only see, first of all, we don't have a compact yet, so it's a moot point, and I'm only licensed in Virginia. But the scope of the regulations is crystal clear. And there's a guidance document that amplifies that messaging as if I didn't get it from the regulation. I can only meet with patients via telehealth using a virtual platform so that I can see them in the moment, and they have to be in the state where I currently am seeing them. If they decide to take a trip to Texas, that's nice. I better be looking for temporary licensure in Texas. So you need to check with, first, is in the order of those established resources, what are your regulations for your state licensure? If it's a compact, you want to be checking in that other state where the patient is. You want to be checking with your malpractice to make sure you're covered, and of course, to make sure you're proficient as well. There's not one answer that fits all, but you always start with the regulatory scope and the language of the law. And again, I'm not a lawyer. I don't play one on TV. We got Lynn Muller for that. But she doesn't play one on TV, but you know what I mean. You've got to check with what the language of your state laws is specific to where the patient has to be and where you have to be. Whether it's the patient and you have to live in the same state, or you have to be licensed in the state where you're treating the patient. It varies based on discipline.
Okay, we have one comment and a thank you from June to you, Ellen. Terrific presentation, so informative. And I agree with that and echo that for sure.
My pleasure. I'm glad that we could do this. I know that you have a lot to do between now and later, and I'll see you all for what I know will be a very interesting session with some people you kind of know, and yeah, about 2:50 or 3 o'clock.
Thanks again, Ellen. Thanks for your timely session. We appreciate it.
My pleasure. Take care all. See you in a few hours.
So just a reminder to everyone.